So we're going to come on now to our first of our three great speakers, and that's Josie Garrett. So Josie is Health Policy Officer at Friends, Families and Travellers, which is an organisation that works on behalf of all Gypsies, Travellers and Roma, regardless of ethnicity, culture or background. And it's an organisation that seeks to end racism and discrimination against Gypsies, Travellers and Roma, and to protect the right to pursue a nomadic way of life. So over to Josie.
Brilliant. Hi everyone. Thank you very much, Neil. Thanks very much to the task force for having me. I'm really pleased to be here with you all today, and thank you also for that introduction. So the thoughts I kind of want to share with you all today come from my involvement in two previous projects that we've worked on at Friends, Families and Travellers. So one is the development of the NHS England and Improvement Commissioned report, Reducing Health Inequalities for People Living with Frailty, which I think we should be able to share a link for in the chat. So this report involved engagement with around 8 different population groups who are at greater risk of living with frailty at a young age as a result of health inequalities and as a result of a high prevalence of multimorbidity. And from this project emerged some kind of simple practical tips for the health and care system around the provision of care for people with multiple long-term conditions, which I'll touch on shortly. I was also involved in the development of the Inclusion Health self-assessment tool for primary care networks. So this was supported by NHS England and Improvement, and it was developed along with a number of VCSE organisations. This is an online tool which is designed to support primary care networks to assess their engagement with inclusion health groups, who are the groups identified as experiencing the worst health inequalities in the UK. So the tool consists of 5 sections and takes around 10 minutes to complete. And once you've completed the self-assessment, you're provided with a unique and tailored guide. And this also includes specific recommendations relating to multiple long-term conditions. So I think we can also share the link to that in the chat now. So to give a bit of background and context to how we became to be involved in these projects, Gypsy and Traveller communities are known to experience some of the starkest health inequalities among the UK population, with life expectancies between 10 and 25 years shorter than the general population, and with a higher overall prevalence of multiple long-term conditions. A recent study from the University of Manchester put that into perspective, and it analysed data from the GP patient survey, and it found that the health of an average Gypsy or Traveller patient in their 60s is comparable to that of a white British patient in their 80s. So given this context at FFT, we know that both preventing the onset of multiple long-term conditions and also of improving experience and outcomes of care for those already living with multimorbidity are of course of vital importance for the groups that we're working on behalf of. So when we set out to undertake engagement work for the frailty report, we had an idea of the kind of key barriers to care for Gypsy and Traveller communities and challenges in terms of multiple long-term conditions. But when we began undertaking focus groups across the 8 population groups involved in the project, we found that while each of the groups we were speaking to are different from one another, lots of the issues being experienced for patients with multimorbidity were the same. And so by working collaboratively, it became quite clear that the issues lie with the system, and it also became clear that there are potentially systemic solutions that might make a difference for more than one group. So to give some insight in terms of the key challenges described by participants, one recurring theme was that service delivery models oriented around single conditions can result in really complex and demanding care schedules for people with multiple health and care needs, and that needs can fall through gaps between services because of a lack of clear accountability across those services. So as one participant described, I was frustrated that I was diagnosed with another illness. I had to have a lot of appointments, but support wasn't really provided to treat all 3 conditions or take them all into consideration. I wasn't sure where to go next because the 2 physical conditions were impacting my mental health. So it was broadly felt by participants that primary care services could offer a kind of natural hub within the wider health and care system where patients could discuss how to manage needs concurrently. That actually limited time with GPs meant that it was difficult sometimes to articulate the extent of a patient's needs in 10 minutes. And this meant that patients could go away feeling ill-equipped to independently manage their conditions long term. So as one participant described, I was just left up to my own devices really. I wasn't having in-depth conversations with the doctor because he didn't have the time. It was just, here's your tablets. So adding to this, it's of course crucial to acknowledge that issues happening outside of a clinical setting have a huge impact on people's health. The conditions in which we live and work are some of the greatest contributors to health inequalities, and on average, GPs in England have reported spending around 19% of their consultation time on non-clinical health matters, which relate to the kind of wider determinants of health. Often, from a service perspective, it could feel that many of these wider societal issues are difficult to respond to, and services may feel overwhelmed, or that they don't have the resources or knowledge to meet all of these needs. Yet, of course, we know that these are huge contributors to health inequalities and to the prevalence of multimorbidity. So this is a big part of why we joined up with other VCSE organisations to create the Inclusion Health tool. So we wanted to make this an easier and more manageable process for primary care networks. And we wanted to offer examples of good practice that highlight simple, kind of practical adjustments that can be made that can have a big impact on patient experience of care, whilst also supporting PCNs to tackle inequalities in their neighbourhood. So, for example, we found evidence that where services had offered extended consultations for patients with multimorbidity, that this has been demonstrated to both decrease GP stress levels during consultations, but also increase patient enablement and improve opportunities for coordinated care. So in the long run, this can reduce the need for additional consultations and the likelihood that needs will reach a more acute stage. We also found that the provision of extended appointments for patients with multiple long-term conditions offers the opportunity to engage with wider non-clinical health needs, such as benefits, employment, and housing that often GPs don't feel that they have the time to support with. And it also provides the opportunity to offer key advice or signposting that can prevent future poor health outcomes. And we also found really good examples of good practice where primary care services had replaced, for instance, annual single condition healthcare reviews for people diagnosed with specific conditions with one 6-monthly multidisciplinary review for patients with 2 or more conditions. And from this, patients noted significant improvements in their experience of care and reported that their care was more joined up and that they better understood how to manage their health and care needs long term. So these are kind of examples of the types of good practice and recommendations that are included both within the frailty report, but also within the final tailored guidance for primary care networks that's produced from the tool. So I guess as a kind of final note from me, really at its core, we developed the Inclusion Health tool around the idea that by reviewing the services that primary care networks provide in line with patient experience, it's actually possible to make quite small changes which will have a really significant impact on the health and well-being of those at the really kind of sharp edge of health inequalities and who are living with multiple long-term conditions. And we really believe in the kind of development of this tool that if we put our energy into making the health and care system most accessible for those with the greatest needs, that this can improve things for everyone. So I think I'll leave it there for now, and obviously happy to take any questions as we go on around the tool or the report. Yeah, thank you.